Thank you for the introduction, Dr. Chow. I'm pleased to present you today's echo round topic, case-based learning on congenital heart disease and shunts. I'm Patrick Prudhomme. I'm one of the echocardiography fellows at St. Michael's Hospital from the University of Toronto. So we'll get this started in no time. So first of all, I would just like to advertise for our echo channel. Dr. Chow did it briefly, but as you can see, we're up to more than 350 subscribers, and the increase in the number of views is exponential. If you miss one of the weekly echo rounds, you can log on to SMH Echo and like our videos and subscribe. There's a broad variety of different topics, from the novice student to the resident to the well-experienced cardiologist or sonographer. So it's a very useful tool in order to learn and to do a continuous medical education. So without further ado, like and subscribe. So for right now, for the presentation plan, so we're going to mainly discuss approximately 10 cases. I cut it down a bit, and it's really going to be bullet points. So I'm going to need all your participation, because otherwise it's going to be a bit boring just to tell you what's the diagnosis, because I'm only going to issue you a couple of images, and then you're going to have to answer, and then I'm going to give you a couple of key bullet points about the congenital pathology. So I just want to put out the disclaimer that I'm not a congenital specialist, but I'm an echo enthusiast and echo fellow. So I thought that this topic could benefit everyone. It could be very interesting to discuss. Okay, so we have our first case. So a 65-year-old female with peripheral edema and abdominal distension since a year. So you have the four views illustrated here. So I don't know if you see the images correctly, but on the top upper left pane, you can see a short axis at the tricuspid and aortic valve level. So you can guess that near the aortic valve, there's kind of a echo dropout, or there's a discontinuous structure. There seems to be a communication of some sort. You can see this in the four-chamber view as well, and there's a flow through that structure. So without telling you more, not to give you the diagnosis, does anybody want to answer in the chat what's the proposed diagnosis? I'm going to leave you 30 seconds. Okay, we have some answers pouring in. All right, you got the correct answer. So it was ostium secundum ASD. Thanks for participating. It's going to be very fun if we continue to participate that way. Thank you, everyone. So for the anatomy of interatrial septal defects, you can see that there's many areas where things can go wrong. So basically, there's multiple areas that can have that can lead to interatrial communication. These all arises from the embryological remnants. So every time that the structures fuse during the embryological phase, if the structures fail to fuse or fail to migrate at specific areas, there can be a defect. So we usually like illustrate the types of defect by the following. So a superior sinus venosus defect at the upper left of the screen. There's the fossa ovalis, which if it fails to close, can lead to ostium secundum defect. There can also be the atrioventricular septal defect near the AV valves. There can be also the inferior sinus venosus defect. and there can be also the coronary sinus defect. It's a relatively frequent congenital abnormality, which for which the prevalence is estimated to be at approximately 1 to 1,000. The ostium secundum, as you just seen, is the most frequent congenital abnormality of the interatrial septum, aside from the PFO, which is significantly a higher prevalence, up to 20 to 25%, depending on some series. You can see that these septal defects are way rarer than patent foramen ovale, and they can the interatrial septal defect can be associated with AVSD, so especially for the Prudhomme type, and they can be associated with the abnormal pulmonary veins connection as well. So keeping in the same topic, there's another interatrial septal defect shown here. What's the type of the defect? I'm going to leave you 30 seconds to participate. I don't know if I open the chat, does it obstruct the view or?
No, we don't see your chat.
Okay, great. All right, so a couple of different answers. I'm kind of glad because it shows that it's a bit more challenging question. So without further ado, it's a sinus venosus defect. So we're going to skip to the next case. So now that it's a 24-year-old male with systolic murmur and hypertension. So you can see the 4 different pain. I won't necessarily give out too much information because otherwise it's going to be too easy. Oh, sorry.
The answer is C.
Yeah, I know. Thanks. Yeah, so Fody got the answer right. Thanks for your participation. So can anyone, does anyone know what is the type of abnormal findings that we can see on the chest X-ray? That's an open-ended answer, so I don't have any answer choices. So if anybody wants to participate in the chat or to talk.
You often, it depends if there's collaterals, I guess, because the collateralization can cause hypertrophy of the intercostal arteries and cause like some notching of the ribs. And you can see an outline of the aorta with the indentation of the coarctation. It has a name, but I don't remember what it is. But it's basically like you see the aortic arch, then you see an indentation of the coarc, and then you see the further distal dilated vessel close to the left heart border. But I can't remember what that's called.
All right, so that's the correct answer. So usually we call out the rib notching or the figure 3 sign. So here's
there it is.
Yeah, exactly. But you were all on it, and there was also participation in the chat as well. I like that. So basically, we can there's a typical notching of the aorta that can be seen on the chest X-ray, and it typically shows like a figure 3 sign. So it's mainly as shaped as the number 3, but they're also in the literature. Some people call it figure 8, but it's rarer. It's a rarer name that we use for this, and they can also be rib notching as well. So you can see also there can be collaterals on the axial imaging as well. So you can see a cardiac angio MRI at the right pane that shows the coarctation and with multiple collaterals.
This is a very common question in specialty exam.
So, so a coarctation, usually the cutoff for intervention would be 20 millimeters of mercury, but when there's multiple collaterals that are formed, this may cause a significant coarctation with a gradient that's less than 20 millimeters of mercury. So it's a typical question we get during our training about what causes coarctation with gradient less than 20 millimeters of mercury. There can be other differential diagnoses as well, but this is the most frequent cause. So the third case is a 75-year-old male with transthoracic echocardiogram obtained for dyspnea. So you can see the images. So there's a long axis view. There's an abnormal structure present. We kind of try to focus on that abnormal structure with the color Doppler. Can also be seen in the short axis view at the level of the aortic valve, and also in the 4-chamber view. So what would be the diagnosis? Is it LA clot? Is it left-sided Chiari network? Or is it a Cor Triatriatum dexter or a Cor Triatriatum Sinister? So I'll wait approximately 15 to 30 seconds for your answer in the chat. All right, very good participation. So you're all right. So it was Cor Triatriatum Sinister as opposition to dexter. So the Cor Triatriatum Sinister is a rare congenital abnormality with a membrane either in the LA, which is called Sinister, or in the RA, which is called dexter, which separates the atrium in 2 compartments. So some of the time it may cause an obstruction of varying degrees, so it can present at different stages in life. Usually we define a significant obstruction by a gradient that's more than 8 to 10 millimeters of mercury. Typically, a Cor Triatriatum Sinister is proximal to the left atrial appendage and separates the pulmonary veins in the more proximal compartment from the mitral valve and LAA from the more distal compartment, but there can be a variation to that rule of thumb. And the symptomatology is similar to pulmonary vein stenosis with pulmonary hypertension also, and heart failure and respiratory symptoms. Okay, so now you're seeing a young athlete who has had syncope and also complains of recurring chest pain. There's also a diastolic murmur that you can hear, and sometimes you're not sure if it's continuous or not. Besides that, event, the patient is relatively healthy. So please answer in the chat if you have an idea. Going to leave you approximately 15 seconds to answer, to 30 seconds. Just going to make it loop manually because the coding for the automatic loop doesn't seem to work. You're going to give you a choice in order to answer if it's more difficult. So some answers are pouring in. All right, so everybody seems to be on the same page as me. So it's coronary fistula from RCA to PA. So for coronary artery fistula, it's often a deviation from normal embryologic development in most of the case, but it can also be acquired from trauma or invasive procedure in rarer situations. The physiologic impact depends on the size of the coronary artery fistula and the structure to which it is connected. The most frequent site of origin in the is the RCA in about half of the case, and the left coronary artery is the origin in about a third of the case. And there's also both coronary arteries that can be that can be involved in the fistula in the very rare frequency in about 5% of the cases. The most common termination sites are the right ventricle in about 40%, the right atrium in 26%, and the pulmonary artery in 17%. So the clinical presentation of the coronary artery fistula can have a broad range of clinical presentation. It can lead to myocardial ischemia, heart failure, myocardial infarction in some cases, pulmonary hypertension, endocarditis, and an asymptomatic heart murmur. Treatment is usually reserved for either more than mild and symptomatic coronary artery fistula, and it's usually treated by surgical means or transcatheter means, depending on the localization of the defect and the local expertise in treatment. So now for case number 5, you got a 40-year-old patient with shortness of breath on exertion, pedal edema, fatigue, and abdominal distension. You can hear a systolic murmur present at a physical exam on the lower left sternal border. The only known past medical history was AVRT, and it was treated medically at a young age, and it did not recur. And the mother had the bipolar affective disorder. Okay, so I'm gonna let you I'm gonna let you answer, but maybe we'll try to let the residents the answer earlier if there's any on the call. So I will start off by the residents for this defect. Okay, I see some answers pouring in. I'm just gonna let a couple of minutes just to see if there are some different answers. Yeah, so you're all correct. So it is Epstein anomaly, sorry. So Epstein anomaly is is considered to be an apical displacement of the septal leaflet from the AV junction, resulting in an atrialized RV. So the diagnostic criteria for the displacement of the septal leaflet in itself is more than 8 millimeters per meter square, or 20 millimeters, depending on the different criteria. There can be also other displacement of the displacement of the other leaflets, and the anatomy of the valve itself can be distorted. The septal leaflet may be elongated, redundant, and have a cell-like appearance. So you can see the image here. There's the right atrium that's very broad, and there's a atrialized RV, and there's also a septal leaflet tethering, and there's an abnormality in the septal leaflet. So the abnormalities associated with the Epstein's are PFO, ASD, accessory pathways, bicuspid aortic valve, subaortic stenosis, pulmonary stenosis, or pulmonary artery stenosis. I meant pulmonic valve stenosis, sorry, and the left ventricular non-compaction. The main indication for surgery for Epstein's are symptoms attributed to the tricuspid regurgitation by itself, heart failure, progressive systolic dysfunction, progressive RV enlargement, desaturation from right to left shunt, and paradoxical embolism. So now you're seeing a 70-year-old man who had a heart murmur in childhood, got lost to follow up. He had some cyanosis when he's trained in his younger childhood, or when he got angry. There was also there is also shortness of breath upon mild exertion. And there's also systolic murmur on the physical exam. The patient had the surgery, but it is unclear what surgery he had, and there's a possibility that it has been a palliative surgery as well, because the surgery has been performed a very long time ago. So it is not clear exactly what surgery it is. So I'm just going to let the answers pour in. So I feel that you're very good at this, so I won't necessarily give you the answer choice right away, because I can see that some people are keen to answer. All right, you're all correct. So it was Fallot's tetralogy. So Fallot's tetralogy is the most common cyanotic defect in childhood, reportedly, as per Braunwald. It's a tetrad of overriding aorta, VSD, pulmonary stenosis, and right ventricular hypertrophy. There is a deviation of the septum, intrabecular hypertrophy, that are the main cause of the pulmonic stenosis, but there can also be narrowing of the pulmonary artery or its branches, or stenosis of the valve itself. The most common association is with the right-sided aortic arch and anomalous course of the coronary with the LAD that originates from the RCA and that crosses the RVUT. So you can see here a schematic of the abnormalities seen in Fallot's tetralogy, as taken from Braunwald 11 edition. So you can see that there's a BSD, with an overriding aorta. There's also a component of RV outflow tract obstruction, and that causes varying degrees of pulmonic stenosis. On the right side, you can see a repair with an outflow tract patch. So we must be aware of the possible complication, such as regurgitation, for example, when there's a follow-up of those patients over time. There's also a relatively new intervention, transcatheter interventions that are more used as palliative means or in different population. For the seventh case, you see a patient that's 27 years old, and you can hear a continuous machine-like murmur. So I'm just going to show you the images. Yeah, I think my codec didn't work that well for the images. So if anybody that didn't see the answer, please answer. Yeah, that was it. So it's a patent ductus arteriosus. So you can see the flow in the pulmonary artery. So the flow originates from the bottom to the top of the screen towards the RVOT. And there's continuous flow upon continuous Doppler interrogation of the flow in the pulmonary artery. So these are signs to watch out for patent ductus arteriosus. So the ductus arteriosus is derived from the distal left 6th primitive arch, connects to the PA in the the PA to the descending aorta in the fetal life, and normally closes during the first day of life. It may remain patent in about 0.3 to 0.8% of the cases, and it may be associated with prematurity. This is anecdotal, but I've seen a couple of patients, mostly from my experience, coming from other countries who've had a murmur since childhood, but that wasn't necessarily investigated, or the exact cause was thought to be functional. And so these patients may present at an older age because of loss to follow-up, or because there haven't been thoroughly investigation in the early childhood. Sometimes some less experienced medical provider may think it's a benign murmur, but usually it's a typically not a benign murmur. So it's usually a continuous machine-like murmur that irradiates to most of the chest. It's pretty impressive when you hear those murmurs. So and it may cause also a wide pulse pressure on the physical exam and differential cyanosis. So cyanosis that varies from the lower limb and the left arm as compared to the right arm. So the indication for closure of the patent ductus arteriosus, I mean, I'm not exhaustive in the review of the indication for closure, but mostly they are recurring endocarditis, left atrial or left ventricular enlargement attributed to the shunt. The PA systolic pressure must be less than the 50% of the systemic in order to consider the closure. And it usually can be performed percutaneously unless other surgical procedure are necessary for other concomitant condition. So you see a patient that's referred prior to a pacemaker insertion for sick sinus syndrome, currently in sinus rhythm. So you see these images. So technically, this should prompt another move, another echocardiographic move, or another consultation, or something else. So if you notice this finding, you might want to do another echocardiographic maneuver. So some answers are starting to pour in. Cody is panicking. Is there a panic button I should know about in the echo lab, Fody? All right.
It's that big red one. Don't touch that button.
Like, I agree with you, Ryan. Like, when in doubt, it's always good to sweep. But the most important like maneuver that we should do in that case would be perform an agitated saline injection. Although I guess all the answers could be right except panic. All right. Yeah, suprasternal view is also a good answer that I didn't put in my choice of answer. So you decided to perform an agitated saline study, and this is what you see. So this is an injection from the left arm. And this is an injection from the right arm. So because you're very sharp this morning, I won't necessarily go through answer choice right here. Could you put the diagnosis in the chat if you know what's the diagnosis right now? All right, so looks like Fody's panicking has paid off. So it was a persistent left superior vena cava. Persistent left superior vena cava affects 0.3 to 0.5% of the population. It can affect up to 5% of patients with congenital heart disease. It can be associated with different types of defects such as ASD, single atrium, VSD, Tetralogy of Fallot, coarctation of the aorta, pulmonic stenosis, and anomalous pulmonary vein return. The thing is, the reason why we were discussing a pacemaker implantation was that failure to recognize this prior to central venous access or pacemaker insertion may lead to incorrect positioning depending on the subtype of defect. So you can see on the left pane that there's some multiple variation of this defect. So for the ninth case, so we're just going to see a basic, we're just going to see a view of the aortic valve, and we're just going to determine what's the configuration. This should be a relatively easy one because there's some good images performed. So don't hesitate to continue your participation. I'm liking this a lot this morning. You're all very sharp. Yeah, so it's a quadricuspid valve. So it's a very rare occurrence, but we must recognize it because it can lead to functional pathology of the valve, such as aortic regurgitation or aortic stenosis. Congenitally abnormal number of cusps is a relatively frequent condition, but it is mostly observed with the bicuspid aortic valve. The population prevalence is varies depending on the studies, but it can range to approximately 1% of population, although sometimes it's more or less. The quadricuspid aortic valve is rarer, with the prevalences relatively ill-defined, but approximately less than 0.05% of the population. There's a small association with the truncus arteriosus defect, and we must assess for valvular function such as stenosis or regurgitation, because it can be associated with this abnormality. Yeah, so it's usually in this isolated condition, but there may be coexisting disorder that have been reported. One study has reported 30% of other congenital abnormalities, but this is way higher than other reports. So I would advertise caution while interpreting the results of this study. But what a systematic study of patients with quadricuspid aortic valve has shown is that there might be association with coronary abnormalities, ASD, PSD, patent ductus arteriosus, mitral valve prolapse, or HOCM. So now for the 10th case. So you're performing a TE for this patient who's had an aortosystolic murmur. I'm gonna leave you about approximately 30 seconds to answer. You're all on a winning streak, so let's not break that streak for now. Let's continue our winning streak. I won't give you choices because you're too hot this morning, so I need to challenge you a bit. I purposely left out some views in order to make it a bit more difficult. So focus on the aortic valve. Yeah, that's a step further from the exact well, not the exact, but the echocardiographic pathology. But this specific pathology can be associated with the syndrome mentioned in the chat. So I'm glad to see that there was at least one case that was more challenging. So you can see here on the top left pane that there's some structure right below the aortic valve near the myocardium. And you can see on the color Doppler that there's when there's systole, there's aliasing right below the valve, and there's also aortic regurgitation. So this is a case of subaortic membrane. So for subaortic membrane, there can be, as said, I didn't want to go too much into details, but there can be association with congenital syndromes, such as the ones mentioned in the chat box. So patient may present exertional dyspnea, symptoms of obstruction, and may present with harsh aortosystolic murmur. It's a good question. I'm just looking at the question in the chat box. I think the valve is also abnormal in this case, but the main abnormality I wanted to focus on for the discussion was mainly the subaortic membrane. But I think you're right, because and I think the regurgitation might be caused partially by the subaortic membrane, but also I think there's probably congenital abnormality of the valve as well. So for the subaortic membrane, we expect a progression over time of approximately 1.4 millimeters of mercury per year, and there's can also be well, the main indication for intervention is symptomatic patient with a peak gradient of more than 50 millimeters of mercury. And also there can be there are some cutoffs of 30 millimeters of mercury of mean gradient that are reported, but mostly when I discussed those cases, when I encountered them during my training, it was a cutoff of 50 millimeters of mercury of the peak gradient that was used. So these were mostly the cases I wanted to talk to you today. Thanks for listening. I don't know if you had any experience with in your clinical practice with one of these cases. I'd be more than happy to discuss about each one of the pathologies if you have questions, or if you have experiences, clinical experiences or imaging experiences with those cases. I'll be more than happy to discuss it.